All right, thank you. We are going to discuss factor 8 transfusion indication as well as, of course, dosage, factor 8 dosage. So we transfuse factor 8 to the patients with hemophilia A or actually factor A deficiency. So this patient, they will have spontaneous hemorrhage even without trauma. So, and they are actually treated with recombinant or human plasma-derived factor 8. So plasma-derived factor 8 is prepared from plasma, which is obtained from patients' donors by a plasmapheresis or from volunteer whole blood donors. So whole blood donors or paid donors by plasmapheresis. So we can do dosage, factor 8 dosage. For example, here we have just a short example of how we can dose factor 8. So for example, we say a 70 kilogram hemophiliac patient with the hematocrit level of 30% has an initial factor 8 level of 4%, which just means 4 units per deciliter or 0.04 units per milliliter. So how many units of factor 8 concentrate should be given to raise his factor 8 level to 50%? So this is our question. Here we have, we're just being asked how many units of factor 8 concentrate. So does not mean just units as packet or just storage units or bag or blood bag. There are units of factor 8 concentrate that should be given to this patient to raise the level of factor 8 to 50%. And you know that the primary level or initial level was 4%, right? So here is the formula that you can use in order to calculate units of factor 8 required for this patient. So we have just to take the desired factor 8 level, which is of course desired to be achieved, minus initial factor 8 level times plasma volume. So you can see that we have already the initial factor 8, right, which is 4%. So they have 4% in their blood, but they want to achieve 50% in blood. So which means that is a desired factor 8, 50%, but the initial factor 8 was just 4%. So times plasma volume, which is not given here because plasma volume is not given. So we are going to calculate it to get the plasma volume. So how can we calculate plasma volume? First of all, of course, before we calculate plasma volume, we must calculate blood volume because it is also not given here. So first, we have to know how can we know blood volume of the patient. So remember that we have a 70 kilogram hemophiliac patient. So which means this patient has 70 kilogram as body weight. So now for us to calculate the blood volume, we have to take body weight in kilogram times 70 milliliter per kilogram. So which means that we are considering that patients per 1 kilogram, they should have at least, or they should possess 70 milliliter of blood per 1 kilogram. So that is 70 kilogram, of course, body weight times 70 milliliter per kilogram, which gives us 4,900 milliliter of blood. So it means a 70 kilogram human or men, they should actually contain at least 4,900 milliliter of blood. So now we have got in actually the actual blood volume of the patient, but that is blood volume of the patient. Now, but we want to calculate plasma volume, but not all blood volume, because we already have whole blood volume, which is 4.9 liter. Now we are going to calculate plasma volume of these patients. How can we calculate plasma volume from whole blood volume of these patients? Then we have to take blood volume in milliliter times 1, right, minus hematocrit. You know, hematocrit can be in percentage, but when we just have to divide by 100, of course, in order to put it to 1. So percentage, because 1 is almost equal to 100%, isn't it? So just take 100% minus the percentage of hematocrit. And what is our hematocrit? So let's look at our question. If hematocrit is also given, so hematocrit level of this patient is 30%, right? 30%, that is our hematocrit, or patient hematocrit. So that means we take blood volume times 1 minus 0.3, or just blood volume times 1%, which and then minus 30%, right? So which means just 1 minus 0.3. Then it gives us 3.430, or 3,430 milliliter of plasma. So this is now plasma volume of the patient. So we can just calculate plasma volume from whole blood volume, of course, by removing a portion which is occupied by blood cells, which means that portion is actually hematocrit. And then we have now gotten plasma volume of the patient. Now it is very easy now to calculate how many units that should be transfused. So then it means solution is 3,430 milliliter, which is plasma volume, times the desired level or desired units minus the initial unit or initial level units per milliliter, right? Unit per milliliter, which is 0.4, 0.04. So then we get 1,778 units. So this is not like units, because this is not like blood, blood bags. You know, when you're transfusing, for example, the concentrates of factors, they have to be labeled how many units that are in that bag of the concentrate. For example, we could just look at factor, for example, factor 8 would contain like maybe 400 or 350 units in that particular bag of factor 8 concentrates. So then we get 1,578 units of factor 8 concentrate. So the assay value on the label can be divided into the number of the units required in order to obtain the number of vials to be infused. So we have to check on the label of the units, and then we divide it by the number of the vials to be transfused. Of course, we can just take 1.7578 maybe divided by maybe 500, if that is the number or number of units on the label that we see. So then you get how many vials to be transfused, or how many bags of that factor 8 to be infused. So only factor 8 products labeled as containing von Willebrand factor should be infused for the patient with the von Willebrand factor disease, or von Willebrand disease. So for example, some of the factor 8 concentrate, they would also contain von Willebrand factor. So then we can also use it in case we are also expecting or suspecting von Willebrand disease. So that's how we can dose factor 8 concentrates, the same way as also factor 9 concentrates, even though, of course, I remember factor 9 concentrates especially for recombinant human factor 9, which is used to treat and manage factor 9 deficiency, which is also called hemophilia B. So the dosage for this factor is calculated the same as factor 8. So, but you have to remember that because the half the dose of the factor 9 rapidly diffuses into tissues, and half remains within the intravascular space. So when we are going to transfuse, we must double the initial dose. So must be doubled, because unlike factor 8, which is transfused as whole and it will be available in the body as whole, but factor 9, half of it will just diffuse into tissues and it will not be useful in blood. So that's why we have to double the units after calculating dosage. So that's how we calculate dosage also for factor 9, the same as factor 8 concentrate. So we can also transfuse albumin. Of course, transfusing albumin is also very important, especially for volume replacement, as well as to treat burn patients, to replace colloid pressure, because burn patients, they are suffering from disturbance of colloid pressure, because colloid pressure, is what we call oncotic pressure, which is always managed by albumin. So albumin with diuretics can induce diuresis in patients who have a low total protein because of severe liver or protein losing disease. So this is the indication of albumin transfusion. So lastly, in case of special conditions, how do we transfuse and how do we cope with pressure in transfusion? For example, in case of emergency transfusion, so there are some rules to follow when we want to cope with problems in emergency transfusion. So patients who are rapidly or uncontrollably bleeding may require just immediate transfusion. So what you do, we have to select group O RBC first for patients for whom transfusion cannot wait until the ABO and resus typing is done. So we can just select group O RBC. So group O negative RBC units must be used if the patient is a female of childbearing potential. So this is the only way you can use group O negative, group O resus negative. So this is only way you can use it. So otherwise, even if it is just very urgent, a resus negative male and resus negative post-menopausal female patients can be switched from resus negative to resus positive blood if only a few O negative units are available or if massive transfusion is required. So this is the thing. So sometimes, if someone is going to give a blood unit without cross-matching, for example, we can just give resus negative O unit to the patient. But in case of this patient is a male patient and post-menopausal female patients, we can just give them resus positive or resus positive, because what will happen is not a reaction. It is just only immunization. There will only be immunization of the patients, and because we have to compare risk and benefit to the patients, resus negative male to be immunized is not really a problem, comparing to the problem of exhausting those units of resus negative, and maybe we have also female of childbearing age. These are really potentially risking, especially from immunization, not like male, because if a male is just immunized, that is okay sometimes for them. It's not like to immunize a female. So that's why if we're in this condition of emergency, we have just to balance between risk and benefits. Then we just switch resus negative male and post-menopausal female patients from all resus negative to all resus positive. If because of inventory problem, in case we may actually have female of childbearing age who may need also O negative units. So that's what you can do when we are having issues of transfusion. So after giving the emergency units, then what you can do, we have to proceed with the antibody screening, and then decision can then be made for selection of additional units of blood. So for example, if you have been giving or resus negative, for example, for female of childbearing age, or just resus positive or blood to resus negative men and resus negative post-menopausal women, we can then proceed with the antibody screening and of course ABO resus typing. Then we can select properly which units we are going to transfuse then. So now also in case of massive transfusion, so then here is not just emergency, but this is massive transfusion. It is just like replacement of one or more blood volume within 24 hours. So, or just about 10 units of blood in adults, 10 units in just 24 hours. it is massive transfusion. So platelets are required if the platelet is less than 50,000, and plasma is needed if the PT ratio is greater than 1.5, or the INR is greater than 1.5, or activated PTT exceeds 6 seconds. So we should also transfuse plasma. So this is when we are just transfusing RBC. But of course, when this test, for example, platelet count is less than 50,000, or INR is greater than 1.5, or APTT is also exceeding 60 seconds, we have to transfuse plasma as well as platelets, even if they are not really requested. So when you are transfusing in massive, right, we have to also add these units. So correct precipitate replacement may be also indicated when fibrinogen is also less than 100 milligram per deciliter in case of massive transfusion. So patient in critical condition and limited supply of type specific blood may require a change in ABO and resus type. For example, when we are transfusing platelets and plasma, not RBC, platelet and plasma, we may just change even the resus type. There's no problem when it comes to resus type. Yes, because platelets, they don't contain resus antigens, right? So we don't care about those things, because platelets, they don't contain resus antigen. So we could just also switch between resus types in order to achieve our targets in transfusion. So then finally, also in case of neonatal transfusion, this is premature infants. So premature infants, they would require also frequent transfusion of small amounts or small aliquots of RBC to replace blood drawn for laboratory test in order to treat anemia of prematurity. Yes, but of course, excuse me, I was suddenly I just left my primary connection. Okay, now I'm fine. All right, so in this case, as you can see, in some cases we are treating anemia of prematurity, and a dose of 10 milliliter per kilogram, of course, should be used, and we expect at least increase of hemoglobin of 3 grams per deciliter. So blood units which is less than 7 days old is preferred in this case, in order to reduce the risk of hyperkalemia, because as long as you are storing blood for a long time, also that will increase the risk of it will increase leaking of potassium from RBC that are stored, which would of course increase hyperkalemia. So, and also to maximize the 2,3 biphosphorus rate level. So, and the blood unit should be also cytomegalovirus seronegative, and also sometimes recall reduced if possible, to prevent cytomegalovirus infection, which can be very serious to the premature infants. But also pregnant women should be given also the same units, cytomegalovirus negative or recall reduced, if the test of cytomegalovirus is negative. So in some cases, so irradiation is also very important. It is also very recommended. Irradiation is recommended to prevent possible transfusion-associated graft versus host disease in either neonatal weighing less than 1.2 kilogram or intrauterine transfusion. So this is where we have to irradiate blood units for for neonatal transfusion. We must irradiate the units in case we are transfusing blood into a neonate with less than 1.2 kilogram body weight, or if the transfusion is intrauterine. That's also where we have to reduce to irradiate that blood units. So, but of course, for a full-term infant or full-term newborn, there's no requirement for routine irradiation. So, and finally, of course, we cannot transfuse blood in oncology. Of course, that is in multiple unit, like multiple transfusion in the case of oncology patients, a patient suffering from some condition like cancers, that is oncology patients. Yes, Xavier, do you have any question? No, there's no need. There's no need. There's what we call routine irradiation, and so there's what you call routine irradiation, and also irradiation of blood from from a relative, for example. Relative, whether the blood is not from a relative patient, relative donor, we have to irradiate it, especially for children and anyone who is immunocompromised. Most commonly, we have to irradiate the units. But in routine irradiation, which it means we're just transfusing any units from store without considering like being blood relative or what, just any units, any particular unit we are transfusing. For this newborn with more than 1.2 kilogram of body weight, we don't need to radiate that unit. But any premature infant less than 1.2 kilogram, we have to do routine irradiation always. So whichever is the unit, so not considering if this is a blood relative unit. And also in intrauterine transfusion, it is mandatory always every unit here to be irradiated. So, but for the relative, that is different. So this is only to consider just any unit for transfusion to these patients. Okay, that's what you can do for this newborn. Now, finally, of course, in some cases, of course, because in oncology units, in hospitals, in most cases, of course, transfusion is routine, and we can transfuse multiple units of blood. So in this case now, because we are transfusing platelets, RBC, plasma, so here it is also very important sometimes when we suspect if a patient, in order to prevent like rhesus immunoglobulin immunization, for example, if you are transfusing platelets, in most cases we don't consider rhesus. So in that case now, it is also very important to give some rhesus immunoglobulin in order to prevent immunization or to protect immunization. So it is very good also to consider actually a dose of rhesus immunoglobulin, because some RBC that will be found in platelets, they can be increasing in the patient, which can actually cause immunization. Because for platelet itself, we don't consider a rhesus. So in order to prevent any case of immunization to the patient, because we are transfusing multiple units of platelets, so it is very good to also give at least one vial of rhesus immunoglobulin to the patient. In case, of course, 30 platelet units have been transfused, 30 units. If we transfuse 30 units of apheresis, it is very important to give at least one vial of rhesus immunoglobulin in order to stop any possible immunization, because those units can contain minute amounts of RBC, which can accumulate and then trigger immunization in that patient, especially those with rhesus negative